We can get started here. It's like we had one additional person jump on. I'm Jared Bartel. I'm a neurologist here at the University of Utah. And thanks for coming to our headache school this week. So I will be presenting on nausea associated with migraine. So why do I have nausea with my migraines is the topic today. It's kind of gross, and I'm sorry in advance. Trying to make light of it a little bit in some of the pictures, but if you have a hard time, listening to this type of thing, or you're feeling nauseated at the moment, I would not push it too much and just wait until you're feeling better. Sometimes even talking about nausea can make people nauseated, and I realize that. So sorry in advance for that, but this I think is an important topic to still hear about. Okay, let me go on to the next slide. Okay. There we go. All right. So just as a quick outline, I'll be talking about, what is nausea, what causes nausea, migraines and nausea specifically, and that'll be kind of the focus of the talk. And then what to do when you have a bad episode of nausea with or without migraine, and then what to do to kind of prevent the nausea associated with migraine in general. All right. So I'm not going to pretend to know Latin or Greek, so I won't try to mispronounce these words, but nausea or feeling nauseated, feeling nauseous comes originally from the Latin for seasickness, which I read derived originally from the Greek for sailor. And so it's always been, the term has always been kind of tied into, just this feeling of movement and nausea, just feeling sick to your stomach, essentially. So and that we can relate to that now too. The nausea is kind of defined as an unpleasant, painless, subjective feeling that one will imminently vomit. So you're about to throw up, you have this subjective feeling that is hard to describe, but it's inherently painless on its own. It can be accompanied by painful feelings, but on its own, nausea in isolation is without pain. It's often associated with other symptoms that can be attributed to involvement of the autonomic nervous system, so the fight or flight system, including sweating, feeling pale, having lower blood pressures, and dizziness are all common accompaniments with nausea by itself. It can also co-occur with headaches, of course. Whether you have migraine or not, as you throw up, that can increase pressure in your body, your chest, your head also, and so that can also cause headaches. We'll be focusing mostly on the migraine associated with nausea, but that can co-occur also. So what is nausea? We think of it as probably a protective mechanism in general. Kind of warns against, if you're about to swallow or you just swallowed something that's bad for you. It's kind of adaptive to have a process in your body that helps you to kind of get that out of you if that does happen. Every individual has their own dynamic threshold for experiencing nausea. It depends on what the circumstances are in the moment. It likely explains the variability between people within that same and within the same individual when you're encountering something that's nauseating, provoking nausea in general. And whether you're having a migraine that day or whether you're having something else that's associated with migraine that day or not, where you are in the cycle of that can make a difference. Nausea on its own can be a side effect also, in addition to just being a warning against toxic ingestion of a substance, can also be a side effect of many things. So anesthesia, chemotherapy we think about can be a symptom of motion sickness, vertigo, another brain process like stroke, brain tumor, or migraine. Which we'll focus on that last part, of course, in just a little bit. So what causes nausea? So this is kind of the little, like the pathophysiology, if you will, or kind of mechanism of how nausea is produced. So there's a vomiting center in the brain here, and I think you can see my cursor, but you can see it written there as well. It's in the medulla, kind of the lower part of the brainstem. It receives inputs from the cortex, so these higher cortical areas, which are kind of the outside of the brain. Also the vagus nerve, which kind of goes from the brainstem and innervates a number of internal organs in the GI system and elsewhere in the body. And then also this vomiting center in the medulla also, receives inputs from this chemoreceptive trigger zone, which is like the nausea trigger zone, you can call it, or the area postrema is the neuroanatomical name for it. And these inputs from the brain can cause nausea in a number of ways. So if it comes from the intestines, then you can have toxins produced by bacteria or viruses. The GI system sends signals through serotonin and this other chemical called substance P, which is involved in pain processing. It sends signals along the vagus nerve and the sympathetic kind of fight or flight system to in turn release more chemicals in the brain, histamine, acetylcholine, which then triggers that nausea feeling. You can also have kind of input into this same center and causing the same symptoms of nausea if it's caused by some sort of vestibular problem. So, this can be, just like this benign positional paroxysmal vertigo, so BPPV, that some of you may be familiar with. It's also associated with migraine. Just having, being on a moving, platform of some kind, being on a boat, even driving in a car, motion sickness of any kind can also trigger those same nerves. And the vestibular nerve, which is the same nerve as what we hear with, kind of releases acetylcholine and also histamine from that nerve to the brainstem, which then can cause nausea and a cascade of other symptoms related to motion sickness. And then you can also have triggering of nausea from signals in the cortex, the higher cortical areas here. I keep pointing you on the wrong side of the screen, but that can be caused by emotional stress or distressing visual images, intense pain, such as, during you get an IV or you get a Botox injection for headaches or nerve blocks, whatever. That can also trigger this vasovagal response, which is can be associated with nausea, lightheadedness, dizziness, those types of things, and can similarly cause nausea. And then the last part is it can, from this chemoreceptor trigger zone, the nausea trigger zone, this area is constantly monitoring the blood and the spinal fluid for toxins and different chemicals that can trigger the nausea response. So it looks for the serotonin, sometimes dopamine, sometimes that substance P that I mentioned earlier. And then also certain drugs that can kind of similarly stimulate the same area, so chemotherapy and other medicines like that. There we go. Okay, so this is a very long, exhaustive list of all of the potential causes for nausea. We're not going to go through really any of these except for this last one, or the one that I've circled here. But just to kind of show you that, when people are having nausea, it can be caused by a number of things, although common things being common. If you have a history of migraine and it feels similar to nausea related to migraine, that's most likely what it is. But this is a list of things that medical providers think about sometimes when someone comes in with new symptoms of nausea, and whether they have other symptoms and their physical exam and other things kind of tilt you one way or the other. But anyway, lots of potential causes. So the things that make us think about things other than migraine with nausea, even in a patient with migraine and they have nausea symptoms, some of the red flags that make us think it could be something else are having the sensation to throw up without first having nausea. That's a little bit of a red flag. Could mean that there's something structurally going on in the brain other than just migraine, which isn't actually a structural neurological problem, but could be caused by something else in turn causing headaches and migraine and nausea. Constipation, diarrhea, and then like abdominal pain can also cause concern for something other than a migraine, because it doesn't always happen with migraines. Really anything that's just out of proportion to what would be expected for migraine on its own. There is an association between migraine and certain GI conditions also. So these are all listed here. So in Crohn's disease, ulcerative colitis, celiac disease, IBS, functional dyspepsia, which is you have this feeling of stomach pain and reflux, but there's no clear cause. H. pylori infections, which causes gastric ulcers, duodenal ulcers, cyclical vomiting syndrome, which is more common in kids, and then gastroparesis, which is common in diabetes and other problems where your GI system kind of slows down, and then GERD, which is gastrointestinal reflux, esophageal reflux disorder. And I won't go into those, but just to say that other GI symptoms, GI conditions can cause similar nausea symptoms and can be associated with migraine also. Okay, so this is one of those gross pictures that I mentioned. So I like to show this because it kind of demonstrates a lot of the main symptoms that we see with migraine. So there's the nausea, the throwing up, the sound sensitivity, light sensitivity, the really bad headache, which is more often on that one side. And then this like visual aura, which is present in like 30% of people. So migraine, like what is migraine actually? And a lot of people that are listening to this probably understand migraine, at least in terms of having felt it themselves or know a loved one that has migraine. But migraine is defined by medical providers as, you first have to have at least 5 attacks in order to say that you have migraine, definitively. And they have to kind of meet these following criteria. So usually they last for several hours, 4 to 72 hours. When untreated, can last a lot shorter if they're treated successfully. And then sometimes they can last much longer than 3 days if they kind of go on to what we call chronify or become a really chronic migraine. But usually that's the time frame. And then everyone's headaches can be described differently, but generally with migraine, we think of it as being more on one side, kind of pulsating, throbbing, moderate to severe intensity, and tends to be worsened by physical activity of some kind, or people tend to try to avoid activity in order to, avoid it from getting much worse, their headaches. And then most people will have both of these, sets of symptoms here. But really, in order to fulfill criteria for migraine, you need to have at least one of these. So nausea and or vomiting is one, and then 2, sensitivity to bright lights, which is photophobia, and sensitivity to loud noises is phonophobia. So that's migraine. And these are the kind of stages of migraine or phases of migraine. And we think of it as having 4 phases, or maybe 5 if you think of like what we call the interictal phase in between headaches. So there's the main thing I wanted to highlight with this slide is that you can have nausea during any of these periods at all. So that's one of the kind of more common symptoms among patients with migraine during any phase of their headaches. It doesn't have to be there, and if it's not there, that's not a bad sign, but or a sign that we need to think about something else necessarily. But a lot of times, patients with migraine will have nausea during this entire period, or at least they can at times. So there's the prodrome, which is, or the premonitory phase, which kind of precedes the headache itself by like 3 hours, as many as several days. And people will have difficulty with a number of things. So difficulty with concentration. They can have trouble getting words out or reading. They can have insomnia, sleep difficulties in general. People tend to yawn a little bit more often, which is one of the weird ones. And then increased urination is kind of a weird one too, but those can both happen during the prodrome phases. That nausea that we've been talking about, sensitivity to bright lights, loud noises, muscle stiffness, fatigue, even food cravings, another weird one. During the aura itself, again, only about 30% of people, 20 to 40% in the literature have aura. And usually this starts between, the timing here is right, 5 to 60 minutes before the headache part starts itself. Sometimes it's longer, usually not, but it can be. And usually visual symptoms are the most common. So they have to be fully reversible visual symptoms. Usually, part of your visual field, like on the periphery or the center, and then it kind of evolves from there over, several minutes. People can also have sensory symptoms. So it mentions this like numbness and tingling feeling, sometimes speech changes, like difficulty getting words out again, or other types of, language problems during the aura. Let's see, rarely It can cause weakness. That's kind of a different type of aura, like a hemiplegic migraine aura, but that's also part of this phase as well. During the headache phase itself, we kind of talked about what defines a migraine headache, but these are some additional symptoms that can happen at that time. So again, the light and sound sensitivity, the nausea, vomiting, loss of appetite, which can go with the nausea, just feeling tired, malaised, kind of worn down. People can also have like involvement again of their autonomic nervous system. So the sweating, the chills, even fever, rarely that can happen, diarrhea rarely. So any of these are possible. And then the postdrome, which is like that migraine hangover, is kind of, it can be kind of like a continuation of the prodrome from before. And actually often they kind of blend into each other if you're going to have like, a headache that kind of follows that next headache. Not everybody gets these other phases, but usually there's some degree of a postdrome after the head pain itself is not so severe. So usually like inability to concentrate, feeling more depressed, fatigue, difficulty understanding things, like your brain is just really taxed out. Sometimes people can actually feel almost euphoric afterwards. I don't see that very often, but that's it is described and is possible. Let's see. Okay, so in general, we think of nausea as usually being associated with migraine, in the majority of cases, or at least 50% of the time. But there were a couple of studies that have looked at this, and in one larger study in patients with chronic migraine, nausea was seen in more than 3/4 of them. Vomiting was seen in less, so like close to 40%, sound sensitivity in 80%, light sensitivity in 71%. And I just mentioned those things because with all three together, that was associated with a longer headache attack duration, like the actual headaches themselves were longer and more severe in patients with all three of these things. So nausea, vomiting, light and sound sensitivity compared to people that didn't have all three. There was another smaller study that was also done in actually Russia, I think, or it was a Russian paper that I saw it translated, where nausea was found actually in a much higher proportion of patients, so 90%. And when nausea was part of that prodromal phase with the migraine, the headache phase itself, the painful phase, was longer and more severe than in people who didn't have nausea in that prodrome phase. So it's hard to kind of extrapolate that much because this was in Russia. The patients selected were potentially different from the average group of people in the United States, not dramatically so, but but this was an association that they found that is interesting to note. Okay, and I wanted to go through the treatment of nausea as the main focus of the talk. I realize we're already 19 minutes in, but I'll try to go through this quickly. I do want to say that this is not intended as general medical information, or sorry, this is intended rather as just very general medical information, and it's not individualized for any one person. So please don't take this as medical advice. You should always contact your headache provider, your primary care doctor before making any changes with your medicines. That's very important. I'm listing the doses here as mostly the starting dose for a lot of these medicines. Sometimes we go up as needed, but usually you'll start at a much lower dose. And then some of these medicines are really like not used very often, but I just mentioned them just to open up the possibilities in your mind that there are still other options potentially available, and whether they're right for you or not, it's hard to say, over this Zoom talk, but you should talk to your doctor about it. So one of the ones we use more often is Zofran. So ondansetron works on serotonin, and we like this one a lot because it doesn't tend to cause many side effects, although it certainly can, and those are listed here. So constipation, fatigue, it can sometimes cause headache. I see that less often in patients who already have migraine, but it rarely can make their headaches worse. And then just a general feeling of malaise too. There's also a dissolvable version, this ODT version, that can be taken and it works about as quickly, maybe a little bit faster sometimes, but the main thing that you should know is that you should also swallow it because it doesn't really fully absorb through your gums too, under your tongue. Even though it's a dissolvable tablet, you need to swallow a little bit, but sometimes that's easier for people to take than just a full pill, which is hard when you're having nausea already. There are some antihistamines that we'll use sometimes too, mostly for specific reasons. So meclizine, which is now also available over the counter, is like this version of Dramamine. Not every Dramamine is meclizine, but so just be careful about that if you were going to get it over the counter. This one is mostly used for like vertigo, vestibular symptoms, but it can also help a little bit with nausea. This one can, like hydroxyzine, just it's a common, these are common side effects among antihistamines, but can cause dry mouth, constipation, urinary retention, drowsiness. Usually just taking it once, like won't really do that too much, but it can, so something to be aware of. Hydroxyzine or Vistaril Atarax is another one. This one can also help with nausea, but it's really more often used for like anxiety, kind of as like a substitute for some other like more habit forming medicines. And I'll talk about one actually in a moment, but hydroxyzine is a great medicine for a lot of things. Because it's an antihistamine, it can help with itchiness. It also helps a little bit with insomnia because it can make you sleepy. But sometimes this is one that we'll think about as like kind of like an add-on to like an existing, like a headache cocktail, for instance. You can use hydroxyzine with like a triptan, and sometimes that's more effective. All right, and then another class, and this one is used more often than the antihistamines for nausea, are the dopamine blockers, so the D2 antagonists. And all of these kind of carry this same kind of risk of sleepiness and also abnormal movements, which are a little bit unusual, but I'll talk about that in a moment. So Reglan is the one I probably like the most. Metoclopramide is the other name for it. Usually start at a low dose, even 2.5 milligrams to 10 milligrams, as needed. It not only has anti-nausea effects, but also works as what's called a prokinetic agent. So it helps with movement in your GI tract. So I mentioned the gastroparesis earlier, which can be a side effect of migraine or just a symptom of migraine. And I like this one, especially if people tend to throw up, like if they throw up and they tend to feel better afterwards. Sometimes that's a sign that we just needed to move those stomach contents along, and you would have alleviated things a little bit faster. And Reglan works really well with other triptan medicines and other rescue medicines. It is more often responsible for these drug-induced movement disorders. So there's different things. Akathisia is one. It can cause dystonia, which muscle or a group of muscles, like in your hand or your neck or your arm or leg or something. And then tardive dyskinesia, that's the most uncommon, but that can be can have these involuntary movements of your mouth and your tongue and your lips, and even your upper face too, but that's not as common. That last one tends to not be quite as reversible as the other ones. The treatment with any of those symptoms is to stop the medicine that we think is causing it, and also to just start with and take a little Benadryl too. If you were to come into the ER with those symptoms, we'd give you Benadryl, and that would usually make things better. So we sometimes will recommend, if you're worried about these, or if you've had them before, these types of side effects, taking one of these dopamine medicines with some Benadryl can actually make it less likely for them to happen. The combination will make you especially sleepy, but sometimes that's good. If you're having a bad headache, you just want to be asleep because the pain will go away. With Reglan specifically, they recommend, because of these issues, to use it no more often than like up to 3 months in a row. Taking it really just as needed. A couple of days a week shouldn't have a problem. You shouldn't have a problem with this medicine and those side effects, but I just want to mention it here. And that 4 to 32% is the incidence of those side effects, but it ranges quite a bit. I don't really see them very often. Really, I can't remember the last time I saw anyone with a movement disorder related to one of these dopamine blockers, but it is possible and it does happen. Compazine is another one, prochlorperazine, that we sometimes will use for nausea. If people don't tolerate, another combination of nausea medicines. Probably not first line, but it is helpful. We can use it in the inpatient unit too. This one does have a higher incidence of movement disorders relative to metoclopramide or Reglan, up to 44% of people, but it does also vary quite a bit depending on which article you're reading. And then promethazine or phenergan is also one that is especially helpful because it can make people really sleepy, and that can be a good thing. Again, like if you're having a bad headache, you want to try to fall asleep. The other thing that's unique about this one is that it has a suppository form. So, if you can't swallow something, you could take it in the other route, which isn't fun, but it's, if you need to, take something that'll get in your system that can work. If you're just throwing up all the time, that's a pill is not going to do it for you. So this one, it has that strong antihistamine effect, so it can cause extra sleepiness, and then it has one of the lower risks of movement disorders. So this one is thought to be relatively safe, but just that drowsiness effect can be kind of limiting a little bit sometimes, but not everyone experiences that. All right, so let's see a couple of some other options here. So lorazepam or Ativan is one that we really try to avoid using. It's really kind of like at the bottom of the list of medicines that we'll use for nausea associated with migraine. Even though it can be very effective, it can cause a lot of side effects. This is a benzodiazepine. It is restricted. It's one of those scheduled drugs, and it is associated with tolerance and has a risk of addiction and things like that. It's also linked, this class of medicines is linked with memory impairment, even development of dementia later in life. And so we try to really avoid giving it to people, past age 50, even 55, somewhere in there, because it can especially cause some issues with memory formation. It can otherwise sometimes cause drowsiness, incoordination imbalance. It can make you feel a little bit depressed, usually not, but that's possible. But this is a good medicine. It has a role, but we try to avoid using it if we can. Steroids in general, but dexamethasone, Decadron, I mentioned here in particular, that one can be used. It can be used orally, but more often we'll give that as an intramuscular IV injection, as like a headache rescue cocktail in the urgent care, the ER, or if you were to come into the University of Utah headache rescue clinic, we have that available also. The other option is we could always use like a steroid burst and taper with something like methylprednisolone or prednisone. Like if you've heard of the Medrol dose pack, that's the same idea, kind of starting at a high dose and then just tapering you down quickly. This doesn't really that idea wouldn't help to stop nausea in the moment, but it can help to break a really bad migraine cycle. And so I put it in this category here. Steroids like this can, even though it's only a short term, it can cause some serious side effects. Usually they're not so severe, but they can be. And so the things that we think about are insomnia, can cause anxiety, this hypomania, which is not quite mania or feeling manic, but you have racing thoughts, you have a hard time, you're kind of all over the place. You might spend a bunch of money, you might not make a lot of sense. That's not real common, especially if you don't already have a history of bipolar disorder, which is where we see mania in. If you do have a history of bipolar disorder, this is something to take in consideration, and we may not want to use steroids for that reason. It can cause elevated blood sugars. It can contribute to acne and weight gain if you're on it for a longer period of time, but usually short term that isn't just really a concern at all. And then Tigan or trimethylbenzamide is one that we used to really like to use, but it is no longer available orally. And so now it's only available in intramuscular injections, which is actually kind of hard to get with insurance. And so I just mentioned this here because a lot of patients that had been on nausea medicines in the past had heard of Tigan, or maybe they'd been on it before and it may have worked for them, but it's no longer available in the United States for patients. That may change in the coming months to years. It just kind of lost its availability in the last year or so, but it has kind of a different type of mechanism, and it can be effective also, but it is still available as an injection. Let's see other options. So we try to get to the root of the cause, which often in these cases we're talking about migraine. And so if you kind of treat the migraine itself, that can often reduce the the sensitivity to internal feelings like nausea and dizziness and light and sound sensitivity, those other things as well. But so we think about triptans as often being combined with anti-nausea medicines, but sometimes on their own. They can also be effective if they treat the migraine. That'll get rid of the nausea, hopefully, too. And then there's these 3 newer medicines. So Nurtec and Ubrelvy are CGRP blockers that usually you have to jump through some hoops in order for insurance to pay for them, but those are both very effective. They don't cause many side effects or drug interactions, so those we like a lot. And then the Gepant, this class of medicines which now for now only contains Rayvow or Lasmiditan. This is another good one that can help to stop headaches. It doesn't cause the same blood vessel constriction that the triptans do, but it's otherwise kind of a similar medicine. This one can cause a lot of sleepiness, and you can't drive for 8 hours after taking it, but it can be very effective for migraine and nausea associated with migraine. But it's indicated for migraine rather than the nausea part. All right, and then I think the last slide on acute treatment, so like rescue treatment when you have nausea associated with headaches. So acupuncture and acupressure, I included this because there is some evidence to support its use. We don't really think of it often in Western medicine, and I'm not an expert in this by any means, but there is some support that shows that this can be helpful. So it's this PC6 point, which is in that little diagram or that little picture here, which can be helpful for like specifically chemotherapy-induced nausea, vomiting, and motion sickness. I couldn't find anything that was specific for like migraine-related nausea. The article that I looked at said there was limited information about this, but it's harmless enough just to try. Basically, you just kind of push on that little area for a few seconds and then switch sides. And I've heard anecdotally sometimes that people will do this and it can be helpful, but I'd probably, if you're really interested in doing this, I'd probably talk to somebody that does acupuncture, more consistently, and to see what they think about it. Let's see. So there's a vagal nerve stimulator that is not implanted. There are implantable vagal nerve stimulators, but this one I included the picture just to kind of show what it looks like. Gammacore can be used for prevention or rescue from migraine. It's also used for cluster headache and hemicrania headaches. This is also thought to be potentially helpful, especially with prominent like GI symptoms or nausea associated with migraine. And so we sometimes think about it there just because the vagal nerve, again, runs down into your intestines and can be stimulated here. And it also connects to the brainstem where the headache center is. So that can be a really effective treatment. This one's a little bit expensive. We do have samples at the INC clinic at the University of Utah. We don't benefit from you getting it, but we like the product. It's FDA approved for migraine, so that's an option to try it out. And then another thing, so aromatherapy. There's a lot of not the best evidence, but there are a lot of work in this area, like essential oils and other things that can be helpful. People swear by them, and I think they probably do work. And then there was the systematic review that showed specifically with postoperative nausea. I couldn't find anything with migraine specifically, but they have a lot in common, and it's kind of a similar feeling. And so they use peppermint, ginger, pine, and then this combination called Queeze Ease, which has lavender, peppermint, ginger, spearmint, and that's what this looks like here. And I think this is available. It's over the counter on Amazon or elsewhere online. And those were all better than placebo in treating nausea. But it's kind of hard to have a placebo when it comes to aromatherapy. So you take that with a grain of salt, but it seems like it is helpful. Let's see. And then the last thing that I mentioned here is rubbing alcohol, actually. So we sometimes do this as a trick in the ER, in the clinic. If you're feeling nauseated, related to a procedure or something else, we'll just kind of tear open one of those little rubbing alcohol papers, the little squares that have like little orange squares that have the rubbing alcohol in them, and have you smell that, and that can actually be really effective in treating nausea acutely. I've read that in South America this has been used for 100 years, and we're starting to learn more about it now. It's not really clear exactly why it's helpful. It probably stimulates the trigeminal nerve up there in the nose, but this was felt or found in one study to be more effective than placebo also. Again, hard to control for such a strong smell, but that could be something else that could be tried. And then I think this is the last main slide I have. So prevention of nausea during migraines. So we think about just medicines that can help with migraine in general. So any of those typical ones that I didn't write here, but topiramate, propranolol, venlafaxine, duloxetine, even Botox, or the newer monthly CGRP medicines like Aimovig, Emgality, Ajovy. But specifically some that have some more kind of evidence for use with nausea, like prominent nausea. So one is amitriptyline. This one is used a lot in like abdominal migraines in kids, and it's thought to be more effective than some of the other ones. And actually all of these medicines can take a little bit longer to start working. They're all kind of like in that antidepressant category. And those types of medicines tend to take a little bit longer just to really start working, but it can, work within the first couple of weeks. This one, like the rest of them, can cause a lot of sleepiness, drowsiness, confusion, dry mouth, constipation. It can be hard to initiate urine. It can also cause some weight gain. But this one, and this one actually out of all of them has the strongest evidence for migraine prevention specifically. And this is one of the first line medicines that we use for migraine. Doxepin is another good one. This one is in the same class as amitriptyline and nortriptyline, if you've heard of that one, but it's a lot more closely related to antihistamines than the antidepressants. This one and amitriptyline too should both be taken at night because it can cause so much sleepiness. And we sometimes take advantage of that with this medicine because if people have a lot of insomnia, which can make their headaches worse, we'll dose this at night to try to see if that helps at all. And it can also help a little bit with nausea, like chronic nausea too, because of its antihistamine effect. And we talked about the antihistamines earlier. And then mirtazapine is also has some antihistamine effect. And it's also actually used for prevention of tension type headache. As it turns out, we're not really talking about tension type headache today. It's not, you don't really usually have nausea with that, but just as an FYI. And this one also similarly can cause a lot of the same side effects and actually also increase cholesterol and weight gain too. Usually not, I don't see that very often, but it can if you're taking it for too long or at a higher dose, or if you're just sensitive to those types of side effects. And then the last one that I'll mention are these scopolamine patches that are kind of unique in that way because you don't have to swallow a pill and it actually lasts in your system for a lot longer. The problem with this one is that you have to remember to take the patch off and be careful with the dosing. You start at a low dose and kind of gradually build it up. But we try not to use this, especially in older people, even past the age of 50, which isn't particularly old, but we just want to be careful with this, except in very specific situations. It can cause confusion, dry mouth, constipation, blurred vision, and then faster heart rates as some side effects. Usually it's well tolerated again, but these things can all happen. All right, so in summary, nausea is a common symptom with many possible causes. We focused on migraine, but it can be a number of things, and talk to your doctor if you're worried about, specific, other conditions, or you just think this isn't just migraine, there's something else going on. And it's certainly possible because migraine is associated with a lot of other GI problems. Nausea can be present during any phase of the migraine itself, which makes it especially hard to treat sometimes. And then the treatment goals are usually reducing like the nausea and the other symptoms like in the acute setting, but then also preventing it to begin with by treating the underlying cause, which in this case, we've been talking about migraine. And apologies for these gross emojis here, but I thought those were appropriate. All right, before I move on to the Q&A session, I just wanted to put in a quick plug for Miles for Migraine, which is coming up. It's August 6th. This is the first year that we're doing it in person. It'll be at Liberty Park. There was one last year too, which was all virtual because of the pandemic. But this year, things have cooled down a little bit at least, so we can do this in person. So it's basically a fundraising event, and also to help support public awareness of migraine and headache disorders in general. There's a lot of stigma against migraine because it's kind of like a silent suffering disorder where people can have migraine, they have to call out sick. and their coworkers and their bosses don't understand it. And so the main idea for the Smiles for Migraine organization, which is a nonprofit organization they have walks like this and runs like this throughout the country in 20 plus cities. But the main idea is to try to spread public awareness and then raise money for centers that help to kind of train more headache providers. And this year, all of the funds that we raise will go towards the University of Utah Headache Fellowship, and that'll go directly into the fund to get another fellow trained up for next year. So to sign up, it's easy enough to do. Just follow this code, the QR code right there, or go to the link that's listed right you'd have to type that in, but otherwise probably following the link or the code is easier. The website's a little tricky to navigate, but just stick with it for a moment and you should be able to find it. You want to choose your preferred way to participate. So whether it's the 5K run, I think the 2-mile walk, or the relax event, or just the virtual only, or even the fundraising only, and any of those are super helpful. So you don't actually have to attend to make an impact for us. You'll want to register and create this race roster account. I don't think I've gotten any spam emails that I could trace back from these guys, so it seems legitimate. The website itself, creating an account, I'm not worried about emails there. But and then you select a team. The U of U Headache Champions is the main team that we have. You're welcome to join us or make your own team. You have to be a team leader or a team captain to make a team, but you could do that and invite your friends and family. And then they'll send you an email for confirmation. If you register and you want a shirt, it'll be these purple shirts with the Miles for Migraine insignia on it. If you don't get a shirt, it's totally fine. But if you still want to show up to the event, just wear something that has purple on it, because purple is the color of migraine awareness nationally, as it turns out. So please join us. We'd love to have any of you guys come. And again, if you can't come in person, that's totally fine. Fundraising only, or even just signing up is helpful in its own right, because we get credit for that.